It's time for the Kim Hammer Show, where you'll learn how your state government affects you, your family, and community. Here's Kim Hammer.
Good afternoon. Welcome to the Kim Hammer Show. Hope you're having a great Saturday, enjoying what would be the last Saturday, if I got my date right, before school starts. So I'm sure kids are out bouncing around trying to get their last Saturday of freedom in before we start next week. And so thanks for taking a little time to join me here on the Kim Hammer Show. We got a pretty full lineup today. I have will be joining me here by radio Dr. Joel Tumilson, who is a physician in outbreak with the health department, followed by Karen McCumpsey, who is the Assistant Director of the Arkansas State Board of Nursing, and we're going to talk about the different rules that are being not necessarily relaxed, but are being waived in order to be able to try to get our nursing staff and other individuals that are in the medical field able to work in a different environment to kind of help out with the staffing shortage in the hospitals and really in every field for that matter, but primarily the hospitals. And then we're going to be joined by Jodianne Tritt with the Hospital Association to finish up the hour. So we got a pretty full hour on the Kim Hammer Show, and thank you for joining me here on 101.1 FM The Answer, or if you're joining us by way of Facebook, thank you for listening in. All right, Dr. Tumilson, thank you for joining me here on the Kim Hammer Show. Physician in outbreak, kind of give the people a little bit of an idea what that is and what it is that you do there for the health department.
Yeah, so I work in outbreak response and working on different types of diseases that cause outbreaks. And lately that's been COVID-19 100% of the time, or at least 95% of the time for the last 18 months.
All right. And so with the one question I wanted to ask you, because yesterday I was actually listening to the radio and they were interviewing the CEO of the hospital down in Hot Springs with Mercy, I believe it was, and was talking about the difference between the Delta virus and the other virus that we've been dealing with. What is the difference between the two viruses? I know that they have the ability to mutate, and then I think, is there a third one coming that actually came out of Africa? I understood there were some new cases maybe here in Arkansas that have been identified. Can you just kind of compare the three, if you would, and just kind of give us an update on that?
Yeah, so the Delta variant is a version of the SARS coronavirus 2, right? It's just, as you said, a mutated version. The part that mutated on it is a portion of that spike protein. Why that's important is that with the Delta variant, this mutation that occurred allows that the Delta variant spike protein to bind more tightly to the receptor on your cells, and that allows it to infect you more easily. So that's why we're seeing increased rates of transmission. It's more infectious, it's more transmissible. That's why it sticks more easily to your cells and thus can get inside your cells and replicate and reproduce itself. So that's the way the difference has occurred, making it more transmissible. The other big difference I'd say with it is there is a little bit of different symptoms, at least initially. Now, the Delta variant can cause all the same symptoms that the COVID-19 causes that we've been talking about for months. However, it's been noted that more people are getting initial symptoms that are a little bit different than they were before with the Delta variant. And with the Delta variant, it seems that initially people are more often getting a stuffy nose, a runny nose, a sore throat, and headache. Those are more common early in the illness. The difficult thing there, right, Senator, is those are the type of symptoms we all love to ignore and just kind of put up with and go around our day, and unwittingly we might be spreading it to other people, not realizing that it wasn't just a stuffy nose, it was COVID-19.
The symptoms that you just mentioned are aligned, in my opinion, or, educate me, kind of like with the common cold or maybe the flu and the things that came on with it. How are people going to be able to distinguish the difference between the flu versus, the new Delta variants, or what would you give them in a way of advice?
Yeah, you're right. It's very difficult. I mean, that's been the case throughout the whole thing, but it's probably even more difficult now with the Delta variant. So what I'd say is if you have new symptoms, this isn't, I've got allergies for years and I've kind of got this chronic low baseline of runny nose and it hadn't changed a bit. If you have new symptoms that come up, yesterday was fine and today I'm noticing I've got a stuffy nose and it's starting to run, you need to take precautions to isolate yourself and then go see your physician. Call your physician, get tested so you can find out if it is COVID or not.
this variance, the Delta variance, I mean, it started off with the original, it started off with the original virus. Now it has mutated to this. And is it possible, or in the lab where it originated, and I don't want to get all political with you because I know you got to maintain neutrality, but in the lab where the original was created, is it possible that it was designed to mutate, or is this something that was created, and then this is just another monster that's been born out of it? Is it possible, or is it not?
No, I wouldn't say that's possible. However, the virus came about initially, this was just a random mutation that occurred over time. Every time a virus reproduces itself, there's a chance that it could reproduce in a mutant strain. Almost every time that happens naturally, it's not advantageous for the virus, doesn't give it any increased transmissibility, et cetera. But occasionally it does, and that seems to be what happened with this Delta variant, first identified initially in India way back in December, January, I believe it was.
And so is there any way to predict the number of mutations that occur, or is it just going to be one of those things we just got to kind of wait and see what happens? And then as far as the pharmaceutical companies, are they having to react to, and I know they're working on, the vaccine for the Delta variants, but is this going to be one of those things where we're going to be playing defense, or will we ever get on offense as far as knowing how to totally get it, killed?
Yeah, it's difficult. We will have to react and adjust. One good thing is if we can, through vaccination, through prevention, suppress spread of the virus enough, the theory is that the less often the virus has a chance to infect somebody else and thus reproduce itself, the fewer chances it has to mutate. So if there's almost no spread going around, there's very little chance that it can make a new mutant that's worse than what we're dealing with now. And so that, I think, is the best hope. Certainly as we see with, it doesn't seem like it to us right now, but the influenza virus actually mutates much more easily and readily than do these coronaviruses. And that's why you have a different version of the flu vaccine every year. They're trying to predict what is coming down the pipe. And so they anticipate that and make a new vaccine. Are we going to end up with something like that for COVID-19? The only time will tell.
Okay. Talk about the mask for a second, not the political side of things, but let me just ask you a couple questions. With the Delta variants, the mask that is, what's the best mask for the Delta variants?
The best mask for any of these variants is whichever one you've got placed on your face, over your mouth and nose, and is fitting snugly. The other requirements for masks are that they ought to be at least 2 layers, all right? A surgical mask, one of the medical masks, is always more than 1 layer, right? So that those will always be fine. People sometimes ask, should I wear a KN95 or an N95? Well, if you've got one and you're comfortable wearing it, the most important thing is that it fits snugly around your face and seals up. That's the case with any mask. So, if you've got one of those, fine, but people should feel comfortable using a regular cloth mask that's more than 1 layer, or a surgical mask, a medical mask, and just make sure that it's squeezing around your nose and mouth and is tight around there. And that's what you need. And some people have asked, well, if this is a more transmissible variant, then is the mask going to do any good? Yes, it will. The Delta variant is not more transmissible because it floats through the air better and gets in your nose more easily. It's more transmissible because once it gets inside you, it binds to your cells tighter, like I said. So masks should continue to be just as effective as they were before, and they're highly recommended.
All right, and let me ask you on the treatment side of things, is are the medicines that are recommended for the treatment of the Delta virus different than the treatment of the COVID virus? I know that sometimes people present to the ER or to their physician. Some physicians seem to be more aggressive about their treatment as far as what they prescribe. Others say, well, when you get to feeling worse, come back or go to the ER. That's a whole nother show within itself. But when it comes to the actual medicines that the health department recommends for treatment of the Delta variants, what are the recommendations so that people would know that when they talk to their doctor, what they might need to be asking for?
Yes, Senator. Those treatments are monoclonal antibodies. Those can only be given by an infusion, unfortunately. However, they ought to be used early in the course of an illness. And so those monoclonal antibodies are indicated for anybody that's got whatever medical condition or other issue that makes them more at risk for a severe case of COVID, right? Anybody with diabetes, obesity, heart disease, lung disease, kidney disease, all those different types of things, pregnancy. Those people should talk about their doctor as soon as they get diagnosed so that they can try and see if they can get set up to go to one of those centers. Their doctors refer them to those centers to get set up for a one-time infusion of the monoclonal antibodies. The FDA actually just approved earlier this week. They can now be given. Those same people who are at higher risk for severe disease with those type of conditions I talked about can now be given it if they have a known exposure. So what they're saying now is you don't have to wait till you actually show signs of the infection. If you know you were exposed to someone with COVID-19, right? I've got a quarantine, but I'm one of these people who's at high risk. I can now see my doctor, talk to my doctor, get referred ahead of time to get that infusion to try and prevent that infection from taking hold with these treatment with monoclonal antibodies.
Which would cut down the admissions to the ER and to the hospital, and hopefully that would bend the curve. That is one of the goals and one of the objectives. Go ahead.
Yeah, that's exactly right, Senator. That's what the main use for these monoclonal antibodies is. They won't instantly make you feel well, but they have been shown to be effective in studies at preventing severe disease and keeping you out of the hospital.
And I'm going to ask you this one last question, and I'll get you come back on in a couple of weeks if I get Karen on here. But the infusion, the availability of the infusion, are they catching up with the demand as more people learn about this? Because I think the supply and demand chain maybe is part of the issue on the infusion. Can you speak to that or tell us where we are on that?
That's actually much better than it was earlier in the pandemic. Until a few weeks ago, we actually had much more supply than demand because people stopped going. However, the rate of people with the rate of infections going up, doctors have been referring more people and more people are getting them. There are infusion centers set up around the state. So if you look on our healthy.arkansas.gov COVID site, there's a spot that you can click on for monoclonal antibodies, and it's got a section down there where you can find, and your doctor can find, if they don't already know, places closer to you that can give you that infusion.
Okay, very good. You're listening to the Kim Hammer Show. I've had Dr. Joel Tumilson, who is a physician at the health department, a physician in outbreak. Dr. Tumilson, I appreciate you taking time out to be on the Kim Hammer Show, and hope you have a great rest of the weekend. Anything you want to say in parting?
No, just encourage people to get vaccinated. It's the best measure to prevent getting COVID-19, as well as taking other preventive measures like masking and distancing and thinking about what kind of social occasions you're going to.
Hey, do you see an uptick in the vaccinations? Are people responding to everything that's being pushed out?
Yes. In the last 4 weeks, we've seen a marked rise in vaccination. I think week on week, it's going up about 70% each week. And so that's been, it's not people have realizing that this is serious again, and so more people are getting vaccinated. And a large portion here in the last couple of weeks have been 12 to 18-year-olds getting vaccinated before they go back to school.
If anybody knows me, you always know I got one more question, Heidi. Just chill for a second. And Karen, hang on. We're coming. Have there been any significant adverse effects to the vaccines in Arkansas? I'm not worried about, well, I am, but Arkansas is my audience. As far as recorded adverse effects to the vaccines, what is the percentage, or are y'all tracking that? Because that's a concern to people is I get the vaccine and, I'm going to have an adverse effect. I may die from it or other things. Just speak to that for a second.
Yeah, those things, I don't have those numbers. I'm sorry, Senator Hammer, I wasn't prepared with those. There have been adverse effects in Arkansas. I'm not aware that anyone has died from a reaction in Arkansas to the vaccine, but I don't have the full data in front of me. The good news is those things, even here in Arkansas, have been seen to be very rare, on the same order that the national data shows.
Okay, I'll tell you what, that I'll get you back on the show and we'll talk about that a little bit, just because that, if people could hear that with regards to the vaccine, as far as it relates to the Arkansas population that's getting it, that might give some peace of mind. Okay. All right, Dr. Joel Tumilson, I thank you very much for being on the Kim Hammer Show and look forward to having you back on. And now we're going to transition, and we have on Karen McCumpsey, who is the Assistant Director of the Arkansas State Board of Nursing. Karen, thank you for being on the Kim Hammer Show today.
Thank you for having me, Senator Hammer.
Very good. Okay, so I am looking at the proclamation that Governor issued as far as declaring a statewide public health emergency, and just a little educational note for the public, and that is when the governor declared this under the new state law, the General Assembly had to come in within 8 days, and we had to agree or disagree that there was a statewide public health emergency. The legislature agreed, and that there was not any joint resolution to terminate the emergency, and so we were in agreement with the governor on this. And there were two specific points that were mentioned on this. One is that the Arkansas Division of Emergency Management is hereby ordered to seek necessary staffing assistance for Arkansas healthcare facilities and hospitals through available avenues to include the Emergency Management Compact. And also, the Arkansas Department of Health is ordered to identify any regulatory statute, orders, or rules related to licensure of healthcare professionals that may be preventing, hindering, or delaying necessary action for coping with this emergency. Once identified, those statutes, orders, or rules shall be reported to the governor, posted on the Arkansas Department of Health website, and shall be suspended for the duration of the emergency, which the emergency is for 60 days. Again, just a little educational under the new state law that we worked out with the governor as far as emergency powers. He will have to submit a letter to ALC, Arkansas Legislative Council of the legislative branch, 10 days before the end of that 60 days to request either to continue it. If he doesn't submit the letter, then it'll terminate at 60 days. So those were the 2 points that the declaration of the statewide public health emergency were issued, which brings you into the conversation. Can you tell us what has happened at the Board of Nursing as far as some of the waivers that have been issued in order to help beef up our nursing population and some of the other areas in order to be able to help staff up our facilities?
Yes, I can. Thank you for that wonderful introduction as far as the executive order that was issued. And as a result of that, subsequently, the Arkansas State Board of Nursing has identified orders and rules related to the licensure of healthcare professionals that we have suspended or waived for the duration of the public health emergency. And there are several different ones that would impact different segments of the nursing population. For example, we have individuals that are, that maybe they're a nurse and they have allowed their license to lapse or expire, and they need to renew it or reinstate it. And then we have endorsement individuals that are licensed in another state and they need to come in. And there may be a number of reasons that they have hesitated to do that. And one example would be continuing education. We have individuals, typically what the requirement is that to reinstate or renew, you have 15 contact hour requirement, 20 hours if you're late, and if you're over 5 years, you have to complete a refresher course. But in light of the emergency, the board has waived the RN and LPN continuing education requirements for those renewal, reinstatement, and endorsement nurses. So we've got a number of individuals that are retired or inactive that are looking at coming back or have already come back because they no longer have to delay or altogether not get renewed because they don't have the required continuing education. So continuing education is one piece, one waiver area that we have enacted. I can continue if you'd like me to go into each one, or if we want to talk about them in particular.
Well, let me ask you a question on that. So, what's the length of time that somebody could have been retired and come back out? Are we talking a year or 2 year, 20 years, or what's the cutoff as far as somebody being able to come out of retirement?
Well, under the declared emergency, there's not a particular time frame. So we have had individuals that have been retired for several years that have come back. Specifically, what they tend to do is to go in and assist with the injections. And during the COVID crisis, we have identified a way that they can locate places that are requesting assistance for specific tasks, and a lot of the retired individuals seem to be heading in that direction. Instead of going to bedside nursing, which they may have been out of for a while, they may want to go and assist with the injections, is what I've seen.
The, one thing that's, last week we approved some money for a couple hospitals to be able to open up some COVID units. One of the requirements in that was that they could not hire nurses from within the state because of and I'll use the word pirating, where, a nurse is hired away from one facility, maybe across town, and, and goes there for a better reason, or for better pay, whatever. But they cannot hire staff from within the state. When it comes to a nurse that is coming out of retirement, are they limited to the area that they can work in? You said that they are coming in to help, like with the infusions, which is a great thing. But do they have the full scope of practice as far as what they did with their nursing license before?
Unless they have some restrictions in regards to coming back with any type of discipline, there would be no restrictions or stipulations as far as practice is concerned. Where that would come in is if a particular agency wanted to hire them and had particular requirements in order or competencies that they had to meet before they could put them in that area. For example, if someone had been out for a while and they wanted to go back into a critical care shortage area, they would probably need to meet the competencies of the facility. But from our perspective, the board's perspective, we do not have any restrictions on where they can go to work.
Okay, and when the emergency over, is that end their ability to do that, or are they back in and they would then have to go back into the cycle of, whatever continuing eds would be required to get their next recertification of their licensure?
That is correct, Senator Hammer. Once the executive order ends, the emergency ends, the waivers will end.
Okay, so they would not be able to continue, so it would be like they would go back into retirement because the emergency is over.
Correct, or the license would be inactivated or expired. They would allow it to expire.
Okay. And we'll get to the other disciplines in a second that you have jurisdiction over that you wanted to list a minute ago, but are you seeing a good number of people respond to this? I know that the emergency order hadn't been out, but, I think it's been a little over a week now, maybe 10 days. Are you seeing people respond to it, or as far as coming out wanting to get recertified?
We're getting a lot of inquiries at this time. I think individuals are weighing their options, and getting the word out is a big priority. That's why we have a COVID page off of our website, and we encourage individuals to look there to see what kind of opportunities and what waivers are available. But at this point, we have a number, not a large number, but we have a number of individuals that have taken advantage of the waiver in this area, but more curiosity at this point. I would like to see an increase in the numbers actually taking advantage of it.
So maybe one of the fears that people have is because we've been, hollering about and I got Jodianne with the Hospital Association coming on after you, or if you can blend in, we'll bring the two conversations together. But just because people are going to get recertified doesn't mean they're going to be put back into a COVID unit necessarily. They could pick and choose, like you said, with the infusion, so that they could, because if they could come in and do that, then that would create movement to where maybe a nurse could move up to a different area, whereas right now they can't, because there's not the movement or the ability to move them up there because of the slots. Is that a fair assessment?
Exactly. That is exactly correct.
Okay. So what other disciplines, you started to go down the list a while ago, what are the other ones?
Well, it still impacts RNs and LPN nursing, but as Arkansas is one of 38 states that is part of what we call the Nurse Licensure Compact. With the compact, RNs and LPNs that reside in another compact state should have what we call a multi-state license that would allow them to work in any of the compact states without having to have a license in that state. So, for example, they wouldn't need an Arkansas license. We are waiving the requirement for them to have that multi-state license in the other state. So, and actually what they can do is they can come to Arkansas, and they may not have a multi-state license in another compact state. They can actually work in Arkansas, and that's a very good benefit, especially for nurses that work on the border. All of the surrounding states of Arkansas that border us are part of the compact, and so especially like with Missouri and Texas, individuals that live right close to those lines, they can cross over and work in Arkansas and get an Arkansas single-state license and be able to work here without having to have a multi-state in their compact state.
With the other states around us, because I know that Missouri, is kind of a hot spot, and Louisiana, the border states around us, do the other states that have declared emergencies, do they have the same latitude that we have given through our emergency declaration to where we maybe have an advantage as far as nurses on the border states that may want to come here with this option?
Some states have probably enacted that, but I wouldn't be able to speak to what it is that they've waived in their particular areas. The 38 states that I'm referring to and the bordering states of Arkansas that are members, we have had that compact for a number of years. So that has provided a lot of flexibility in being able to let the nurses come across. But as far as waiving that during the emergency, I don't know that the bordering states have done anything with that. I have noticed a number of nurses taking more advantage of this at this point because they are using traveling contracts to going back and forth to the different states.
Okay. I tell you what, can you hang on through my break? Jodianne's going to join us, and let me blend y'all two together. Can you hang on through the break?
I certainly can.
Okay, very good. You're listening to the Kim Hammer Show here on 101.1 FM, The Answer. I have on right now Karen McCumpsey, who's the Assistant Director of the Arkansas State Board of Nursing. When we come back from the break, we're going to be joined by Jodianne Tritt, who is with the Hospital Association. And thank you for listening, and we'll have you back here in just a second after the break on the Kim Hammer Show. Welcome back to the Kim Hammer Show here on 101.1 FM, The Answer. Thanks for joining us. If you're watching via Facebook Live, thank you for being here today on this beautiful Saturday. Just have Karen McCumpsey, who is the Assistant Director of the Arkansas State Board of Nursing, on the show today. And we're going to be joined by Jodianne Tritt with the Hospital Association. So, Jodianne, thanks for joining us here on the Kim Hammer Show.
Absolutely. Thank you for having me.
Okay, so I've got Karen on, and we're talking about the emergency proclamation and the options that have been created in order to bring in some more staff that otherwise maybe have been retired. And let me ask you, Jodianne, just from the staffing perspective of the hospitals, what is the current status, or what would you say as far as the percentage that you're down in nurses and how that is limiting being able to open up more rooms in the hospitals?
Well, I'll tell you, you couldn't be more right. The physical space that we have for hospital beds in Arkansas is still pretty great. And I say pretty great because we were very concerned, especially early in the pandemic, about how we would look, right? And of course, we all have what we call COVID fatigue. Everyone is exhausted. Everyone's trying to do everything they can to keep people safe and to keep our hospital rooms open and available. And the number of patients that we have is just growing every day. We actually surpassed yesterday on Friday the number of patients that we had in the peak in the winter. So to give you a really good example, there are more than 400 open registered nurses jobs in Arkansas hospitals right now. And that's based upon one of our sister companies who helps us go out and try to identify really great talent and bring them into Arkansas when we need them. So on any given day, we have more than 700 staff out to furlough due to either isolation or quarantine. And so that's higher than it was even in July when we had about 460 folks out. And I can also say there's been a 25,000% change in travel registered nurse demand in Arkansas from May 2020 to July 2021. So again, we're trying to do everything we can to bring in amazing talent to help us staff the beds that we have to keep people safe and healthy in Arkansas.
Okay, the 25,000%, break that down for those of us that are a little simple-minded. Run by that number again.
Sure. Okay, so there's been a 47% increase in the average registered nurse contract rate since April and May to July 2021. So if you think of 25,000%, you can say, okay, today I need 5 travel nurses because I'm staffed everywhere else okay, but tomorrow I need 1,500. So that's the difference. And I'm using wrong numbers here. I need to get you the raw numbers, which I can absolutely do. But when you have that kind of percent change on need, you're in a big trouble. And it just goes to show that Arkansas is competing with other states for talent. As this pandemic has gone on and on, other states are experiencing some similar increases in patient volumes. And so we're basically in a bidding war with other states to try to make sure we get the right personnel to staff our hospitals so that our Kansans are covered and taken care of.
And one thing that we did this past week, past week, I'm trying to get my weeks together. It's been a long 3 weeks, but we approved some funding for the hospitals to be able to help in that recruitment. Talk about that for a second.
Yes, you did, and we could not be more grateful. What we're planning on doing, and we're waiting on the Department of Human Services, who was definitely our partner in this. We created an opportunity for every hospital in the state who is taking care of COVID patients. So not the rehabilitation hospitals and not the freestanding inpatient psychiatric hospitals. Not that they don't do great work, but we're trying to think about physical COVID care that needs to occur at the very basic level. The legislature authorized hospitals to receive a per bed allocation, if you will, to use for nothing but staffing. We can recruit new staff, we can retain the ones we have, and then we can acquire staff to help us really take care of patients. So that per bed allocation, those hospitals can request it. And with those hospitals knowing that they can request it, it gives them a little bit of freedom and loosens up their purse chains, if you will, a little bit, so that they can enter into those travel nurse contracts. We are highly encouraging every hospital who participates in this program to request only out-of-state nurses. One of the worst things that can happen to us is we start stealing nurses from each other's sister facility, right? Your hometown hospital, Saline Memorial, if it steals all the nurses from St. Bernard's and Jonesboro, that doesn't help us take care of more Arkansas patients. All that does is inflate the prices for traveling nurses. So we are really laser focused on doing everything we can to request from staffing agencies and other entities for new nurses coming into the state. We want them to be out-of-state nurses. And we applaud the Arkansas Nursing Board for helping us increase that number, even with students and everything else, so that we can really work together.
Well, and just, you may have heard about this or may not, hate to break the news to you, and by the way, I know you just got back from a vacation this week. I do hope that you and your family got to spend some quality time together and us legislators weren't bothering you too much. But I've already heard of one case where that has happened, where a hospital actually had a out-of-state contracting service that hired a nurse in-state from one hospital in one town and was going to move her to the hospital in the next town over, and administration found about it and put a stop to that. Do we have any written guarantees that that is not going to happen, or is that something that we as legislators are just going to have to stay on and, as we hear about it, try to put it? Because I don't know how we can actually interfere with the business of independent hospitals when it comes to that, or what are the assurances on that?
Well, and that's a really difficult thing. You're absolutely right that a lot of those businesses and corporations are even outside the purview of our hospitals. So I'll oversimplify what I'm about to say, but many times our hospitals have to use staffing services in order to acquire new talent. So a lot of times those staffing agencies and companies, they'll recruit anybody they can, right? Because those staffing agencies who are going out and doing their best to recruit people who will then become travelers to work in Arkansas also have other states where they're trying to recruit folks to work. So we're really hoping we can use the resources you gave us to keep the folks that we have now from going into Missouri or Texas or Oklahoma or Louisiana or any other state so that we can take care of our Kansans first. There's likely not anything we can do to require that because, once again, that most of these corporations that our folks have to use to contract with, they're contracting agents and entities, and they're doing their best to pull talent from everywhere. I can say that we are diligently working with those staffing agencies that the Hospital Association has any kind of purview or visibility in to really make it imperative that those folks have a preference. We're also encouraging our hospital CEOs and human resources managers who are having to fill out these usually long applications for these contracts that we're entering into to get new talent into the state to make it a strong, strong preference for non-Arkansans in the first place. And that way we can help really look at our talent and resources and think about how many dollars we need to use to incentivize our folks to keep our nurses and our respiratory therapists and other staff that are really hard to come by here in the state, rather than them taking those new contractual jobs and leaving the state to go somewhere else. So we're definitely having to balance that, and we're encouraging, once again, the staffing agencies that we know our hospitals will contract with to really seek out-of-state talent first.
Okay, Karen, let me ask you, with regards to the nurses that may be coming coming out of retirement or taking advantage of the waiver program, if they come out and they get that waiver, does that allow them to be able to go out of state if a out of state contracting agency says, hey, do you want to go to New England and practice for 8 weeks?
Well, based on the waiver information, it basically just enables the nurse to obtain their licensure. It doesn't stipulate what agency or where they would be able to go to work. So in reality, yes, they could go for a contract in another state or another country. That would be up to the receiving agency on whether or not they would accept the license that they had, whether or not they were able to cross state lines or whether or not they had to apply in that other facility. So there is no way to stop them except if the receiving agency had some kind of stipulation that would prohibit them from going.
What happens when, let's just say 60 days from now, the emergency is terminated and they're on a 12-week contract out of state through a traveling agency, and the emergency terminates here in Arkansas before their contract would end if they were out of state? How would that scenario play out?
Well, if they had a Arkansas license, if it went inactive, they would need to have a license in the state where they were going to be working. So what a lot of individuals do is they may have their Arkansas license, and then in order to go to another state, if it's not a compact state or if their receiving state, their rules have not been waived, then they would go ahead and try to attempt to get a license in that state as well. Just depends on what level of waiving that the other states have enacted.
So let me ask you, as far as, and listen, we appreciate our nursing staff. We appreciate every person that works in the medical field right now. I mean, even the person that keeps the room sanitized and cleans, after the COVID patient leaves or while the COVID patient's there. We appreciate everybody, food service, nurses, everybody, okay, doctors, ER. We haven't even talked about the ambulance personnel yet. But so with regards to what are you seeing, Karen, as far as nurses that are leaving the profession, and are they leaving the profession because COVID has just finally been the straw that broke the camel's back, or are they just leaving because they've just gotten tired of it, or what are the reasons that you're seeing that nurses are leaving the industry?
Where I'm located, I really don't see when they actually leave. A lot of individuals would contact us and maybe they're moving to another state. What I see is individuals that are contacting us and are going to work in another state on a staffing contract. I see a flow of nurses, of Arkansas nurses, that are drawn to the COVID contracts of other states, and so they're going out to those areas and working. So I don't really see them when they actually leave nursing. I know that we have a population of those that may be doing that, but where I see the gap, per se, is when the nurses actually decide to go to work in another state because that contract is more appealing than staying in-state.
Jodianne, with what we did, and listen, I said the legislative branch, let's include the governor in that. This was a team effort, okay? I want to make sure to get that disclaimer out there. As far as the money that was given, are we going to be able to be competitive? Will the hospitals, with the additional money that was allotted, are we going to be able to be competitive? But part of the dilemma is you've got the nurse that was there pre-COVID, during COVID, will be there after COVID, and their salary has been what it's always been. But then you've got a traveling nurse that's coming in from out of state that's going to work right alongside that nurse, and that traveling nurse is going to make no telling how much more money than that person that's going to be there after that traveling nurse leaves. To both of you ladies, I'd ask you, how much of a disadvantage is that to the morale of the nurses and others that would benefit from this? And what are your suggestions as far as what we need to do to combat that?
Well, I'll start. It definitely is a disadvantage. We have so many nurses, respiratory therapists. You're right. The amazing folks that we have inside the hospitals who are really loyal to their own facility. So we have a lot of disincentive, if you will, for those folks to keep their morale high. So to your point, one of the reasons the proposal is written the way it is to allow retention of staff in those arenas. We most definitely want to reward the staff who are still within our facilities, and we've got to do everything we can to keep our really great talent from leaving the state and going out and working in another state, because they can issue a contract that's more user-friendly, more friendly to those staff than what we can do, which is the exact reason we requested the money. Many times these staffing contracts are about 60 days at a time. Some of them are longer than that. They can be 5 weeks, 8 weeks, 10 weeks, etc. So the hospital's agreement is with the staffing agency. The staffing agency then has its own agreement with what those individual nurses will make under the contract. So we have to be really careful to make sure whatever we do to our existing regularly salaried, regularly employed nurses is at least comparable to what the travel nurses are getting, so that we don't lose what we have. As my papa used to say, sometimes you got to hold what you got, and we definitely need to do that too.
Karen, any thoughts?
I totally agree with what she said. I do have another area of opportunity that we've reached out to the Hospital Association and other healthcare facilities as far as another pool of individuals. We have upwards of 1,000 nursing students that are anticipating graduation by December of this year. And so the board has made some exceptions as bold initiatives aimed directly at nursing students and nursing programs to try to help mitigate the impact that COVID-19 has been having on healthcare staffing. So those exceptions are monumental. We have not had them previously in the last episode of the emergency declaration. So it is something that we hope that the hospital associations and facilities will be able to take advantage of.
So let me ask you, just to put people's mind at ease, and I know the answer to this question, but I want people to hear it. So we're gonna relax these standards. You've got nurses maybe that have been out for 3 or 4 years. They want to come in and help out because that's the nature of a nurse. They want to help. They want to be in the middle of it. That's why it's a calling. It's not a job. You've got students, 1,000, and not all of them are going to be dumped into the field, but some are going to take advantage of that and see the opportunity of that. Have we lessened the quality of care that individuals will be receiving by doing this? I know we're in emergency. I know we're kind of like all hands on deck and we're all, the seams are bursting, but are we compromising the quality of care that patients are going to be receiving because of these waivers and because of these efforts?
I think that's really a two-part question as far as the individuals that are returning to nursing. They have years of experience in whatever area that they've chosen to work in. And then one measure that's in place that is not going to be waived is the requirements facilities have as far as competencies to be sure those individuals, when they're placed in an area, they know their scope of practice, they know what particular competencies they're able to do, and they function within that. We have not relaxed the requirements that nurses be responsible for knowing their scope of practice. And as far as students, the measures that we have in place for students, there are 3 areas that we have sent information to the Hospital Association about. One particular one, the individuals are licensed practical nurses that are enrolled in their final semester. So we're talking about individuals that are in their final semester of school, RN or LPN program. These particular ones are in an RN program. They've been licensed as an LPN, and they have the opportunity to work on a registered nurse temporary permit. And that individual would still have their scope of practice that's holding them to that standard, as well as orientation and competencies wherever a facility wants to hire them. The board has also created information to help guide the individuals that may hire these individuals, so that the employer will know what the expectation can be and where this individual can work as far as their scope is concerned. We also have what we are calling, or what is called, the academic practice or practice academic partnership, and it's an innovative model built on the foundation of collaboration between nursing programs and a healthcare facility. And in this particular instance, it's a two-way partnership so that students could be employed by a facility in a certain role and receive compensation and academic credit while working in that facility with faculty oversight. So the faculty are still there and evaluating them and monitoring them. It's just they are in a support role so that licensed nurses are able to move more toward the front line, and if a facility works out the plan that way. All underlined by the fact that we have very specific guidelines and criteria that have to be met for these areas to be utilized in this time of need.
Jodianne, anything to add to that?
Absolutely, and I completely agree with Karen. I will say, and you know this, Senator Hamer, I'm an optimistic person and tend to always look for the glass that's half full. One of the things that we're excited about in working with the nursing board and how they're reviewing which students we can take within our hospital facilities is that our students, their students, are actually going to get that great clinical experience. So when the great day does come, when patient volumes decrease, we're going to have even more qualified, even more experienced folks helping us take care of patients. I also will add, our nurses, respiratory therapists, janitors, food service, physicians, all the healthcare workers are so exhausted now that sometimes they do have to take on more patients on a shift than normal because of the patient volumes that we have. So when you add students into that mix, the opportunity for more people to help with that patient actually helps soften the fatigue and some of the overwhelming exhaustion that's being experienced by folks who are literally doing more with less. So we are very happy about this opportunity to get more folks in our facilities. Karen's absolutely right. They're quality trained. They know what they're going to do, and we've got a really great opportunity to give them some clinical experience earlier in their training than they would normally get, which is going to do nothing but make the field of nursing even better in the future.
I'm down to less than 2 minutes. The one thing I think that would be noteworthy is that out of all of this, if it allows us to look at the way in which we've always done things to see if it would open up the opportunity to do things differently in the future in order to, help improve the process. I do think that's one thing that's positive that's going to come out of this, just by the sheer fact that we're having to do things we wouldn't have otherwise done under normal circumstances. That doesn't mean we're going to compromise quality or that we're going to, produce any less of a better product. It just means that we have created new options that otherwise we might not have ever looked at. I'll give you all each 15 seconds. I'm down to a minute. Y'all, Karen, you got anything you want to say in 15 seconds? Hey, tell people where can they call or what can they look at as far as getting information, Karen?
We do have a wealth of information on our Arkansas State Board of Nursing website. If they go to healthy.arkansas.gov, follow the board link until you get to nursing. And under the Arkansas State Board of Nursing, we have a COVID page that lists the things I've discussed, as well as some additional measures we have in place to try to assist facilities in nursing as well.
All right. Jodianne, anything?
I just want to say thank you so much, and thank you to the Nursing Board for collaborating with us and doing everything we can do together to improve patient care and to take care of the staff that we have. So thank you to the legislature, the governor, and all of our healthcare partners across the state.
We will get through this together if we just keep plugging away. We've had on the radio show, on Kim Hammer Show today, Dr. Joel Tumilson, who is a physician in outbreak at the health department. Thank you, Jodianne Tritt from the Hospital Association, and Karen McCumpsey, the Assistant Director of Arkansas State Board of Nursing. We appreciate you very much listening to the Kim Hammer Show. Just remember, if you would, please obey the basic recommendations and guidelines. We will get through this together, and we'll be better for it. We'll be stronger because of it, and we will show that nobody can get us down as a nation if we just keep pushing forward. Thank you for listening to the Kim Hammer Show here today on 101.1 FM The Answer. Hope you have a great rest of the Saturday.